This module is on clinical correlations for VEPs. Prior to conducting or interpreting a VEP examination, it must be established that the eye and retina are functioning normally. This is why, for flash VEPs, we place a rudimentary ERG electrode to ensure that the retina is functioning before we interpret the VEP. And for pattern reversal VEPs, we require measurement of the visual acuity in both eyes before conducting the test. And it's important to note the visual acuity on the reporting forms for the person interpreting the study. If there is an eye or retina problem, this can degrade the VEP response and it would be wrongly interpreted as a cortical dysfunction when really the problem is in the eye and the stimuli is not properly getting to the brain. Some ophthalmologic disorders that can affect the VEP include refractive errors, that's why it's important to measure visual acuity, opacities of the cornea and lens, which would degrade the quality of light getting into the eyeball to the retina, glaucoma, and then interestingly, retinitis pigmentosa affects the VEP, but it affects the flash VEP, but not the pattern reversal VEP. The criteria for calling a VEP abnormal are delayed N70 and P100 with the latencies above the upper limits of normal, an entirely absent response, or the observation of interocular latency differences in the order of 6 to 10 milliseconds. For long latencies are the clinical standards that we use to call a VEP abnormal. In our lab, we use the standard of 3 standard deviations above the mean for an age group before we call a VEP abnormal. And so 3 standard deviations is quite generous and encompasses about 99% of the population. In adult labs, 2.5 standard deviations is the typical cutoff that's used. There may be times that we may see that the latency of both eyes are within the upper limits of normal, but there's a difference in the latency between the two eyes. And if this difference between the two latencies is in the order of 6 to 10 milliseconds or more, then the later eye is considered abnormal. Amplitude is not typically a criterion used to call a VEP abnormal, except in the case where the VEP is entirely absent, or in the very rare cases where the VEP is of very, very low amplitude. However, it's very difficult to interpret this without seeing some sort of asymmetry between the eyes. And so if there is an asymmetry between the two eyes, then the eye that shows an amplitude that is 50% less than the other eye is considered abnormal. There may be cases where there is an abnormally high amplitude VEP observed, and this may indicate a myoclonus or a seizure disorder. This is a case example of a patient who shows an asymmetry between the left and right eye. So in the top tracing, this is a pattern reversal VEP from the left eye, and the middle tracing, the middle lines, are from the mid-occipital electrode. And you'll know that the N70 and P100 have latencies of approximately 70 and 100, and the amplitude of the P100 is approximately 20 microvolts. Now looking at the lower right recording, this is from the right eye, you'll note that the N70 and P100 from the middle tracing have latencies of approximately 100 for the N70 and 130 for the P100 with an amplitude of approximately 10 microvolts. So based on amplitude and latency differences between the two eyes, the right eye recording would be considered abnormal. This is a table of VEP abnormalities that may be observed and their potential clinical correlates. And so starting on the first line, if there's a binocular absence of the VEP, one must first rule out technical problems. And then if technical problems are ruled out, then one could consider ocular abnormalities where the eye is affected and therefore affecting the VEP, or else one could consider severe bilateral optic nerve defects. Now, if the VEP is absent in one eye, The clinical correlate is an optic neuropathy or an eye disease in the side that has the abnormal VEP. With regards to latency, if there's a prolonged latency of the VEP, then the clinical correlates that one can consider is some sort of optic nerve lesion or optic neuritis or a demyelinating condition. And as we've discussed earlier, if there's an interocular latency difference, if there's a latency difference between the two eyes in the order of 6 to 10 milliseconds or more, one can consider again an optic nerve lesion or optic neuritis or a demyelinating condition in the eye that shows the later latency. As previously discussed, amplitude is not a criteria that we typically use to call the VEP abnormal. However, if there's an asymmetry between the two eyes, then one could consider an ocular lesion, particularly a compressive lesion in the eye that has the lower amplitude. If the amplitude of both eyes is very low, then one could consider an ocular lesion or a lesion in or around the chiasma. But it must be noted that low amplitudes with well-formed waveforms and normal latencies might be normal. And finally, if a VEP is not expected, so for example, in the case of cortical blindness, and then a VEP is acquired, this is often a good prognosis for cortical blindness. And this is a table showing the VEP abnormalities that we would expect with different sorts of lesions. And so with an ocular lesion, a lesion at the eye, we would expect to see an absent VEP in the affected eye or a very low amplitude VEP in the affected eye. If there's a lesion in the optic nerve, then we may see an absent VEP in the optic nerve that's affected, or we may see an increased latency in the VEP, or we may see an increased asymmetry, an increased interocular latency difference with the eye that's affected showing a longer latency. If there were a lesion at the optic chiasm, we may see abnormal binocular full field VEPs, but more specifically, we would see this abnormality showing up when we test the temporal hemifields of both eyes. And that's because the temporal hemifields or the temporal visual fields activate the nasal fields, the nasal retinal fields, and it's the nasal retinal fields that cross over at the chiasm. And so if there were a lesion at the optic chiasm, then it would be this stimulation of the bilateral temporal visual fields, which activate bilateral nasal retinal fields, that would show the abnormality. If there were a lesion at the optic tract, the optic radiations, or at the occipital cortex, the binocular full fields may look normal, and the best way to test for a lesion in these areas would be to do a half-field, a hemifield recording. And so in this case, the corresponding half-field stimulation would show an abnormality that corresponds to the side of the optic tract, optic radiation, or occipital cortex lesion.